This video will demonstrate diagnostic cerebral angiography, specifically showing technique using an angled diagnostic catheter. This is the case of a 33-year-old former U.S. Army veteran who presented to the VA complaining of several days of headache and dizziness. The patient was neurologically nonfocal, but had a CT non-contrast head exam that demonstrated a lesion suspicious for AVM in the posterior fossa. CT angiography was obtained in order to further evaluate the vessel anatomy. We see axial, coronal, and sagittal images demonstrating hypervascular nidus in the region of the cerebellar vermis. Angiography commences by obtaining femoral artery access, in this case using a 5 French short sheath. An angled diagnostic catheter is advanced into the aortic arch over a wire. Once in the aortic arch, the wire is withdrawn, and using puffs of dilute contrast, the catheter is navigated into the vessels of the arch. Here we see selective catheterization of the innominate artery with selection of the carotid artery on the right-hand side. A run is obtained in order to evaluate for stenoses at the bifurcation. Here we see none. Then the catheter is advanced using puffs of contrast to keep the tip off the wall to prevent dissection. We first select the right ECA in order to evaluate for external feeders. A run is obtained from the right external carotid artery using slow, constant pressure in order to obtain complete opacification. The catheter is then withdrawn under fluoro guidance into the bifurcation, at which point the internal carotid artery is selected. Using short puffs of contrast and maneuvering the catheter is brought into a stable position within the internal carotid artery. A run is then obtained from the right internal carotid artery, demonstrating complete opacification of the arterial tree. We see a clean capillary and venous phase, demonstrating no feeders into the AVM. The catheter is then withdrawn from the right common with selection of the left common carotid artery. This is done again using short puffs of contrast to evaluate for position. Again, we evaluate the common carotid anatomy to assure no stenoses prior to advancing into the vessels. The left ECA is again selected using puffs of contrast and positioned so as to opacify all vessels. A left external carotid artery injection is obtained, again using slow, constant pressure to opacify all. We want to assure filling of the occipital branches, which we see here. The catheter is then withdrawn using puffs of contrast into the common carotid, at which point the internal carotid may again be selected and the catheter advanced with twisting movements to avoid dissection of the vessel. A left internal carotid artery injection is then obtained. Here we see the arterial, capillary, and venous phases of the injection. The catheter is then withdrawn from the left common carotid with selection of the subclavian. We see here that the vertebral artery is selected using short puffs of dye and advanced with cautious puffs to prevent dissection. A vertebral artery injection is obtained, showing the cervical anatomy, followed by intracranial anatomy. Here we see a vascular nidus. We see here the hallmark of an arteriovenous malformation, specifically appearance of venous structures in the arterial phase. We see feeders from the posterior inferior cerebellar artery and posterior cerebral artery. A 6-vessel angiogram is useful for evaluating all arteriovenous malformations, and thus we obtain access to the right vertebral artery by readvancing over the aortic arch and into the subclavian. Once in the innominate, we obtain a road map in order to selectively catheterize the subclavian. A wire is advanced in order to select the subclavian artery, and the catheter is advanced over the wire. Often, the angle of the vertebral artery takeoff requires that another road map be obtained and wire used to select the vertebral artery, as we see here. Wire is advanced into the artery, and the catheter is then subsequently advanced into a stable position within the vertebral artery. At this point, the wire is withdrawn, and again, we can obtain injections from the vertebral artery to evaluate the vasculature, here in cervical projections and cranial projections. We see again the vascular blush of the arteriovenous malformation with early venous drainage and feeders from the posterior cerebral artery and posterior inferior cerebral artery.